Good morning. Typically we start with a disclosure. I have no relationship to the Tea Party. That's my disclosure. If anybody wants to talk about that afterwards, you're welcome to address me. Thank you. All right, so let's get going. That's everybody knows what this. Where is my arrow? This is Delicate Arch in Arches National Park in Utah, from whence I come. And this is another delicate arch. Seen here is the superior semicircular canal, and that'll be in our talk. So let's begin with a quick anecdote. When I started head and neck radiology, I was telling this in the hall, 30 years ago, they were just finishing with tomography, and all of the neurotologists of the world thought that radiologists were a completely useless bunch of people because we gave them misinformation constantly about their diseases of the temporal bone, and I had to convince my neurotologist to actually listen to me. Because CT was just coming in, and we ushered in this new arena of real information that helped patients. And we'll talk a lot about this, but in fact, from that point where we were 2 millimeter, 3 millimeter CT without edge enhancement to today with 3T MR and CT, bone CT as it is at 0.6 millimeters, there is so much to see in the temporal bone, it's somewhat overwhelming. And so today we'll try to look at some of this and sort through it and leave you with, hope, some impressions of that. All right, so this is just something that was sent to me recently by a radiologist that knows that I'll answer his emails. And he said, what is this thing? What is that? Okay, there's something in the head of the malleus. There's something in the body of the incus. Is that normal? And there are can be little fatty marrow spaces in both places, but we never could see them before, maybe 5 years ago. So it's an example, because this is what they usually look like typically. So it's an example of things that we're seeing now that we wonder, is that normal? And so if you're doing temporal bone CT, it's pretty important to begin to understand what you can discount and what you need to pay attention to. Today's lecture will talk a little imaging techniques, not for long, normal anatomy, clinical correlates. Anytime I will talk to you about some general normal anatomy, I will then take that to the extreme as we move through the talk, and we'll see, I hope, some things you haven't seen before. We'll look at MR as well briefly, and we'll talk about some of the new structures you might be seeing or not seeing that are looking at you. So when we talk about the modalities we have to use in the temporal bone area, we have temporal bone CT. As I said, it can be anywhere from 0.6 to 1 millimeter in thickness. We have many different views, which we'll talk about in a moment. And it is a fabulous tool for the fine detail bony anatomy of the skull base and the temporal bone. However, if you see anything leaving the temporal bone that's large, or there is tissue that you're trying to characterize, CT doesn't really do that for us, and so we move then in terms of tumors and inflammatory complications to MR with contrast, fat saturated usually. Here we see a glomus jugulare paraganglioma. And then if we're looking at the interlaudatory canal with all of the T2-ish sequences such as CIS, Fiesta, and T2 space, we have a way to look at and create very surgical images of the interlaudatory canal. Temporal bone CT. In our shop, we do use obviously multi-slice technique with 0.6 millimeter slices. We do a routine coronal, a transverse oblique or short axis oblique, and long axis oblique. And so we have 4 sequences we routinely look at. Usually we use the transverse and longitudinal images just to check off and look at things a little differently, although there are times that it's very helpful. They are very helpful. Coronal image, a short axis or transverse oblique shows us the superior semicircular canal and the bony vestibular aqueduct, which we're starting to see there. And we see things like superior semicircular canal dehiscence beautifully with that technique. And here is the bony vestibular aqueduct, also seen best in the transverse or short axis oblique. Then long axis oblique, we have, or the longitudinal oblique, we see the cochlear turns beautifully. It can be very helpful if you're looking at a cochlear implant or looking at labyrinthine ossificans to characterize where the big plaques are. Gives us a nice look at cranial nerve 7, where we see the stylomastoid foramen, the mastoid segment, and tympanic segment under the lateral semicircular canal. So that's CT and the techniques we use in brief. So we'll move on from there to some anatomy. As I said, some of this anatomy will be known to you and obvious, and hopefully just a quick review, and some of it will get, I hope, a little more detailed. So we're going to focus today, because we have 30 minutes, on middle ear and mastoid anatomy, inner ear, bony and membranous labyrinth, and then the intratemporal facial nerve. You hear the term epitympanum or attic. This is the middle ear cavity from the scutum to the tympanic segment of 7, if you draw that line, and above. This is the epitympanum or attic. The mesotympan is from that same line to the line from the tympanic annulus to the base of the cochlear promontory. And so there's the mesotympanum. And then finally the hypotympanum is below that line from the annulus over to the base of the cochlear promontory. So 3 main areas of the middle ear on the coronal plane. The other critical middle ear anatomic components that we talk a great deal about are the ossicles and then the walls of the middle ear. And specifically, we'll talk some about the epitympanic area and the mesotympanic area and their walls. So let's start with the middle ear and mastoid axial images, and let's look again at this middle ear area. And we'll just highlight the lateral semicircular canal and its bony covering. And remember that this sticks out in the middle ear and therefore is available for dehiscence from a large cholesteatoma. We have the lateral epitympanic recess, which has 2 pieces. Above, it's the lateral epitympanic recess proper, and then below, Prusak space. We'll highlight that further in a moment. We have the tympanic segment of 7, and we have the adytus ad antrum, or entrance to the cave, and the cave being the antrum of the mastoid. Moving to the coronal, kind of magnified right ear temporal bone. We'll just go through this list. Don't worry about the speed because we'll revisit it when we talk inflammatory and infectious disease. But we have a scutum. Whoop, that was kind of interesting. Let's try that. Scutum, which we expect to be sharp. Normally, we have trouble seeing a normal tympanic membrane. We have the lateral epitympanic recess, and just the very lowest portion of that is Prusak space. We have the tegmen tympani, which can be variably ossified and very thick or almost evanescent in terms of the view, and so you have to get used to that range. Some of the people like to call this sort of the duck's beak. This is the lateral semicircular canal fluid space covered by the bony covering on the coronal image. Mid-tympanic segment of the facial nerve, cochlear promontory, middle ear floor, and the tympanic annulus and tympanic membrane. Again, not seen. Focusing now on the ossicles. We expect to see in the low epitympanum the head of the malleus, the body of the incus, short process of the incus, and the malleoincal articulation. So-called ice cream cone for those of you that like ice cream. Moving along then, other things you might see in the low epitympanum. You have a part of a cog, the epitympanic cog, which may go all the way across and attach to the cochleoform process, and which can injure the tensor tympani tendon if it's removed surgically. We have the lateral epitympanic recess, we have the anterior epitympanic recess, we have the lateral epitympanic recess, we have the adytus and the mastoid antrum again. So we see those areas. Mastoid drainage. Sometimes it's hard to imagine, okay, mastoid is making fluid, and it's washing the entire middle ear clear, and then the fluid goes out into the bony eustachian tube. If you try to imagine, okay, it's being made here, and it's kind of coming through the adytus, and then it comes into the middle ear itself, and then it goes out through this. It's probably better seen, I think, if we look at it from the perspective of a longitudinal oblique image, where we see the mastoids are making fluid, we come up into the antrum, into the adytus ad antrum, middle ear, and then out into the bony eustachian tube. Notice that the hypotympanum is not deriving the bony eustachian tube. That's actually the anterior mesotympanic wall. Now we're moving down to the mid-mesotympanum through the, and if you notice the line goes through the oval window, and we see the ossicles again, and we see two dots, and we should always see two dots. We see the manubrium of the malleus, and we see the long process of the incus. Remember, there's a little hook on the bottom of the long process, which is called the lenticular process, which then communicates with the stapes. So then we also now should expect to always see two crura of the stapes and the area of the oval window. Anteriorly, we're seeing the tensor tympani tendon turning through the cochlear process. The tensor tympani tendon is innervated by 5. Nicely, it's nice that the stapedius, which we'll show you in a moment, is innervated by 7. So if you knock out one nerve, you can still expect to have some dampening of sound by the other muscle. Notice that behind the pyramidal eminence, we see two dots that are sort of joined. The one that is medial is the stapedius belly, and the one that is lateral is the mastoid segment of 7. And that brings me to the posterior wall. Let's see, I think we got oval window, and then we'll move to the round window, and then we're to posterior wall. And this is a W-shaped structure if you have a prominent pyramidal eminence, which we do here. And so we see what's called the facial nerve recess, an important surgical landmark with the mastoid segment behind it. And then more immediately, as we said, we see the belly of the stapes in the pyramidal eminence. And then finally, we have the sinus tympani. It's classically taught that cholesteatoma can get in behind the sinus tympani and not be visible to the surgeon doing a proper mastoidectomy. But this is a pretty rare phenomenon, really. Other things to see in this area. On the coronal image, we're talking the cochlear promontory, the tympanic segment of facial nerve. On the coronal image, the oval window and the round window posteriorly. So oval window here and round window here. Notice that you can see the facial nerve is always up away from the oval window, and we'll highlight what it would look like and why it might not be there. There's another view that I like on the short axis, which we call the two-window view, which we can find very helpful. So if you put, this is the oval window, and notice in this case, the stapes footplate is just barely visible, and the round window has the air in it, and the round window membrane is here between the basal turn of the cochlea and the air of the round window niche. But if we take that short axis oblique and project it, we see beautifully the round window niche, the membrane of the round window, and the oval window with the facial nerve. So it's a nice alternative view if you're suspecting something like oval window atresia and want another, not completely orthogonal, but another view of it, which is the two-window view. Coming back to the muscles again, we'll just briefly go back to those two. We have a stapedius muscle, which we said we see in the pyramidal eminence. We know that a tendon comes off of it and goes over to the hub of the stapes. Very difficult to see that. That's the mastoid segment of the facial nerve. So it's not visible in most cases. On the coronal right ear image, we see the in the axial image, we see the belly of the tensor tympani muscle anteriorly. Notice it turns, and we see the tendon there of the tensor tympani muscle going over to the malleus. And on the coronal image, we see that even better, where we see the tendon going through the cochleoform process and emerging over to the malleus. There are two other things we see in this area. We see two more dots. The anterior one is the anterior tympanic segment of the facial nerve, and the more medial one, lateral one, and the medial one is the labyrinthine segment of the facial nerve. We'll come back to those when we get to the facial nerve. One more comment about the oval window. As we said earlier, the oval window is obvious. There's a nice niche to it, and the facial nerve is always a few millimeters out along the lateral semicircular canal bony component. The other area I just brought up is in an area just on the anterior margin of the oval window, and the term fistula and fenestrum, or a cleft of the area of bone anterior to the window, or antefenestrum, is there. The cleft is actually not seen in the developed temporal bone. This is an embryological structure. And this is the area where the most subtle forms of otosclerosis occur. So we'll see that, I think. So here's a nice small otosclerotic, so-called fenestral otosclerotic plaque, which is right where we'd expect it to be on the anterior margin of the oval window in the fistula. On the left, we see a patient who has oval window atresia, quite significant, and we can see that the facial nerve has moved down the lateral semicircular canal and is actually between the surgeon and that bone. So that would be an observation that you'd like to make, because if the surgeon tries to operate on such a patient, that can be a contraindication to trying to do a oval window opening procedure. All right, ossicles again. The malleus, as we talked about, has a umbo at the bottom. It has a manubrium, or long process, and it has a head, and it has a little isthmus or neck. The incus has a body, a short process, a long process. This is the lenticular process, and here we see the stapes, which has a neck, crura, and footplate. Let's quick look at those. Again, in the epitympanum, we've already defined a head and a body and short process of the incus. As we go inferiorly, we see two dots. We expect that to be the manubrium anteriorly and the long process posteriorly with the crura. And if we go one more down, we see the little lenticular process as it turns to the, over to the stapes with a long manubrium down to the umbo. I think we're going to move ahead here because we got a little late start. Okay, ossicles can be seen in the long sagittal view, and here we see the incus and the malleus, and looking at articulation in the longitudinal view is very helpful in trauma. The incus and stapes in the transverse view, again, we can see them beautifully. We see the anterior crura, in this case, in the short view, and we see the tympanic segment of the facial nerve above manubrium malleus, and the tympanic membrane just barely visible. Stapes crura, one last view. You see both of them. You can, in the longitudinal view, you will be able to see both crura going to the oval window, posterior and anterior. So some of my thoughts in the middle ear. The middle ear landmark that's useful is the tympanic annulus. The lateral epitympanic recess is not equal to Prusak space. It has two components, and the lower one is Prusak space. And we see these three recesses with the things we mentioned in them. So let's move to the inner ear. The inner lymphatic structures are the chambers and organs of the inner ear. We see them here in the darker blue. They have endolymph in them. The perilymphatic structures have the perilymph in them, and the light blue, and they surround these structures. And the osseous bony labyrinth surrounds this all. Here's a high-resolution 3T image of a magnified cochlea. Notice we can see the modiolus, which we know has the spiral ganglia and spongy bone. We can see the scalar chambers. The anterior chamber is the scala vestibuli. The posterior chamber is the scala tympani. We cannot see the scala media routinely at this point. In higher field, we can, and this is going to be of great interest over the next decade, I believe, in Meniere's disease. The vestibular system itself, let's just look at the bony labyrinth for a moment. We have the crus communis, and we have the analymphatic duct and sac. The sac itself has an intraosseous component and an intradural component seen in the fovea. And the duct is short, and the sac is intraosseous and intradural and long. And we can't tell when we've moved from duct to sac. Just an example of some pathology that would be helpful. We see in this case the very short, you see the enlarged bony vestibular aqueduct and the very short duct that's going to the crus communis. And we see the sac, both its intraosseous and its intradural components, and the very short duct. Notice also that we see a large anterior compartment, so this is scala vestibuli, versus the scala tympani, which is small, which is the most subtle version of a cochlear dysplasia. Using T2 space or Fiesta or CIS, we can see all kinds of wonderful things now in the inner ear and the interlaudatory canal. Here we see the anterior and superior nerve, which is facial, the superior vestibular nerve, the cochlear nerve, the inferior vestibular nerve, and we can routinely see these nerves, and if we're not, then we know we have a non-diagnostic scan with these techniques. And then the modiolus. Let's talk briefly about the facial nerve. Remember that the facial nerve begins in the brainstem, exits the cerebellopontine angle, moves out into the interlaudatory canal, and it is the anterosuperior nerve, which we see here. Goes labyrinthine, geniculate, tympanic, and mastoid, and then out into the parotid. So when we look at an oblique sagittal image of the IC, we can expect to see all the nerves now, which is a very helpful image when we're looking at cochlear implant patients. Here we see the labyrinthine segment exiting anteriorly and superiorly over to the anterior genu. The tympanic segment seen here. And then, again, we can expect to see all four nerves, so this would be the facial nerve. If you have, in this case, labyrinthine ossificans with complete obliteration of the cochlea, you may have denervation atrophy of the nerves. In this case, we see that the cochlear nerve is completely absent, which would be very useful to know if you're about to do a cochlear implant on this patient. It may not be absolutely a contraindication, but it means that you're likely to have a subpar outcome. Now, moving on with the facial nerve, we'd expect to see all of the segments. We can lay it out on the longitudinal oblique, and we can see all these components. I think we're going to move ahead a little bit. Excuse me. Okay, this is what I wanted to get to. So when the facial nerve exits along the labyrinthine segment, this is a patient who has a rare, very robust Bell's palsy with a huge enhancing tuft, labyrinthine segment, tympanic segment, and the greater superficial petrosal nerve shown here diving under the Meckel's cave area. So we'd expect to be able to see the beginnings of the greater superficial petrosal nerve, but then we lose that canal on CT. But it reappears to us as it enters the Vidian canal in the skull base. And here we see it doing that. So we lose it, and then it drops down, and we see it re-entering the base of the Vidian canal here. And so we can begin to study the facial nerve throughout this entire course. That's the Vidian canal there. In fact, this drawing just highlights that. So here's the greater superficial petrosal nerve going under Meckel's cave and over to the Vidian canal and out to the ganglion, sphenopalatine ganglion, and then the lacrimation fibers go up through the inferior orbital canal and up into the orbit. A couple of other things that we now see, I think we'll again move through to that area. That is, we can now routinely, I believe, see the chordotympany nerve as it exits the mastoid segment of the facial nerve. Remember, chordotympany nerve has both anterior two-thirds of tongue taste and parasympathetic fibers, efferent and afferent, in it. And as we look at that area on a sagittal image, here we see the chordotympany nerve coming into the middle ear cavity. If we go to the axial image, we can see the mastoid segment and the exit of the chordotympany nerve. We see it there and moving and there. So it's going to exit into the middle ear. We've seen cases where it swings quite lateral and has been injured in a traditional mastoid approach. And we haven't studied that yet, but I believe that that could be done at this point. And here we see it exiting the mastoid segment on the coronal image, and we see it here. A couple more things to show you, and then we'll wrap it up. In the jugular foramen area, just medial to the temple bone, we see that the jugular foramen is divided into two pieces, the anterior pars nervosa and the posterior pars vascularis. Notice Jacobson's nerve has a tympanic branch that goes through a canal and up onto the cochlear promontory, and it's this area where we have paraganglia cells that can create the opportunity to have a glomus tympanicum paraganglioma. Then more posteriorly we have the vagus nerve, which gives off the auricular branch, which is the Arnold's nerve over to the mastoid segment of 7. And so you can also have a very rare glomus facialis lesion that can occur along that nerve. So let's first look at, this is the jugular foramen and the nervosa component here. Notice the nerve canal coming across here. This is Jacobson's nerve canal. We see it here and here and here, and it's just about to go up, and it goes up in the cochlear promontory. There is a very subtle notch there where the tympanic nerve is up on the cochlear promontory. This is just drawing of that same thing where you see it come up, and this is the glomus body that would create the opportunity for the glomus tympanicum paraganglioma. Coming back then to Arnold's nerve, or the auricular branch of the vagus nerve, and we see it come across, and we can pretty much routinely see that exit from the pars vascularis headed over to the mastoid segment. So structures that you can see now that sort of begin to observe the greater superficial petrosal nerve as it enters the Vidian canal is visible if you just look down in that area at the base of the Vidian canal, or most internal aspect. The chordotympany nerve can be seen coming off the mastoid segment, as we've highlighted. Jacobson's nerve canal coming across can be seen, and Arnold's nerve can also be seen. So people ask me, do you do obliques routinely? We do. We find them very useful. I've just highlighted some of the uses for you today. The cochlear, for the longitudinal view, cochlear turns, the cranial nerve 7 laid out in its long view. Stapes crura can be seen. The malleoankle joints can be seen in the case of trauma. And mastoid drainage is kind of an interesting thing to see, but not probably much clinical use. From the transverse perspective, the spurious hemispheric canal, this is a highly useful view. It's been discounted as not really useful if you have good coronals, but to me, actually measuring the distance of the dehiscence, that view is a wonderful view. I use the 2-window view to look at oval and round window if I'm suspicious of something. And then finally, the bony vestibular aqueduct is beautifully seen on the transverse view as well. So with that, I will thank you for your attention.